So as I said that we are starting this series with ovarian cancer on the things which we should be, keeping in our head whenever we are seeing any patient. So whenever a patient calls us, comes to us or calls us with some sort of gynecological problems, this in front of you is a chart which is kept in all the GPs, in all the gynecologists, in every office, just to have a quick check, because sometimes a patient is coming with some other complaint, either infertility or fibroid, and we can miss, picking up the cancer. So what they do is, so
Yeah.
this chart is basically not a very specific, but a generalized chart. Whenever a patient is coming to the top set of symptoms or signs, the patient will go to pelvic mass clinic, which is basically ovarian cancer detection clinic. The middle set of symptoms will go to the endometrial one, that is the postmenopausal bleeding clinic. The third set is cervical symptoms, goes to colposcopy clinic, and last is the vulvovaginal clinic. Now, today, I'm just discussing about pelvic mass clinic, which is suspecting ovarian cancer. So I will discuss these symptoms in detail in the next slide. So what happens when a patient is coming to a GP, or now here in India, they directly goes to their own doctors, the gynecologist. If they are presenting with symptoms like, you know, already scan diagnosed abnormal mass in the pelvis with ascites, which is suspicious of cancer, then definitely they directly go to the cancer surgeon. However, not all ovarian cancer are coming at that stage. Some of them comes with some non-specific symptoms, which are highlighted here. So what symptoms are they? If the patient is coming with persistent or frequent symptoms, we call them as like more than 12 times per month. Nobody is keeping a record of how many times, but if they are coming to you, that must be troubling them. That's why they are coming to you. So if a patient is coming with a bloating sensation or abdominal distension, feeling full, or you say loss of appetite, a pelvic or abdominal pain, and then bladder and bowel habit changes like diarrhea, constipation, or bladder habit changes. Or we say in like whenever there is a diagnosis of IBS in any female above 50, before diagnosing IBS, you have to rule out ovarian cancer in that age group specifically. Unexplained weight loss, generalized fatigue, malaise, and as I said, change in bowel habits. These all symptoms, if comes to your clinic, we definitely order an ultrasound of abdo and pelvis. This is something which we do. There is something coming on the background.
Swesha, Dr. Swesha, Dr. Swesha, kindly mute yourself. Is by mistake or probably. I'll
Yeah.
try and give her a
आरती
हो गया
आरती की
Yeah,
मैं
yeah.
multi नहीं कर सकती ना.
Huh. So, if these set of symptoms, we usually order an ultrasound abdo and pelvis. That is a natural good practice. But I want to ask actually everyone that how many of us are ordering CA125 with these symptoms? Unless there is
It's quite a routine now.
now, okay.
It's
So the
quite a routine.
CA125 and ultrasound abdo pelvis, these two things has to be ordered in these set of symptoms. Now, what will you do with it? Now, the CA125 is a marker which is usually raised, we say, in a certain set of ovarian cancers. So whenever a patient has got a raised CA125 and an abnormal ultrasound, the referral needs to go to a surgeon. And what happens? The CA125 more than 35 in a postmenopausal women and more than 200 in a premenopausal women is what we say as a referral criteria. But if the CA125 is raised and the ultrasound is normal, that is when the confusion starts. Then you have to assess what are the other causes of raised CA125. So usually it can be a chest infection, a urinary infection. Even when taken in menstruation, we know that it will come back as raised CA125. So unless the CA125 is raised in thousands, if it is something about 100 or 150 or something like that, and if the patient's symptoms are not very severe, you can repeat the CA125 within 4 weeks of time to see the trend of the CA125. This is what I'm talking about when the ultrasound is normal. Nothing is showing in that. If not, if you think the patient's symptoms are really severe and they are becoming more frequent and persistent, then definitely we need to investigate with a better scan, which is a CT scan, CT chest abdo-pelvis. That is what we recommend. So that is when the CA-125 is raised. If a CA-125 is within normal limits and the scan is normal, then definitely we have to look for other causes of these symptoms. Now, going forward, sorry, going forward with the same set of symptoms which I explained, we have made a small acronym just to highlight the symptoms. That is BEAT, BEAT. So B is for bloating, abdominal swelling, E is for eating difficulty, A is for abdominal pain, and T is for toilet, that is bladder and bowel habit changes. Then loss of appetite, loss of weight, and fatigue are further. Other than the symptomatic patients, we have got some cancer nurses which basically analyze each and every female who's walking to the hospital for any risk factors for ovarian cancers. So, if a patient has been classified as high risk by doing that risk factor analysis, even if she is asymptomatic, we have to just on the precautionary side do a ultrasound and a CA-125 just to be like not to miss the ovarian cancer. I will discuss about this risk factor analysis in the next slide. So now if these patient, either asymptomatic or symptomatic patient, has got an abnormal ultrasound and a CA-125, usually the next steps what you are already doing is to, we have already screened the abdo-pelvis, she will need a chest imaging. Now, when it comes to CT, MRI, and PET, I'm not sure what we are doing here right now, but what our practice back there is whenever the ultrasound is showing a ovarian mass which is of inconclusive nature, then definitely the patient needs an MRI to further characterize the mass. If it is looking malignant, then you have to have, we do a CT scan in the stages where CT scan or a PET scan. So this is a bit of a debate, I would say. In West, in UK, we are only doing a CT scan, but in here in India, I know everybody is going forward for a PET scan, just not to miss any distant metastasis, which is the right thing to do. But make sure that you're not ordering a PET scan in a patient who's acutely ill. Like, for example, a patient came to me with acute pancreatitis, had a CT scan on which incidental finding of ovarian cancer was picked up. Now, if in that patient I will do a PET scan, everything will light up. She's got an acute inflammatory condition. So make sure your patient is not having a PET scan in acute illness. That will not be a justifiable. So in that case, a CT scan will be a better scan to pick up where the cancer has gone. Coming to next, we always order after a CA-125 a set of tumor markers, which is LDH, HCG, alpha fetoprotein, inhibin. The general practice is to order them in less than 50 years of age, but there's no harm even in ordering in more than 50, as I have seen granulosa cell tumor in a patient 55 years old. So it's not a definite cut mark. Again, CBC will show you a low hemoglobin and a raised platelet count without any particular cause. Again, a definite red flag for cancer, underlying cancer. Then other two tumor markers I would suggest also to do are CEA and CA 19.9. CEA is basically a bowel cancer marker, and CA 19.9 is a hepatobiliary marker. I'm just asking, I mean, of course, this is
It's very
something we will do once the patient comes to us with a ovarian cancer, just to rule out that this ovarian cancer, as we all know about Krukenberg's, is not coming from the bowel or hepatobiliary. So, but in why I'm telling you this is basically when a patient is already having all these sets done, why not to write these two as well? I mean, it will save time and the hassle as well for the patient. So, once these tests are done, yes, the second thing I wanted to tell you is about the asymptomatic patients, because risk factor analysis is very important, what we are doing with the help of our cancer nurses. So, about the risk factors, the first risk factor is definitely age. So, any patient who's coming, of course, after the age of 50 to a gynecologist, there's something wrong there. So, either uterine cancer, ovarian cancer, every cancer risk is higher whenever a patient who has achieved menopause is coming to a gynecologist with some sort of gynae complaints. So, age, whenever a patient walks into your room, is again a red flag. The second comes to the genetics and the family history. Sometimes we are in a rush and we don't take the family history, and that's very normal to happen. But nowadays it's very important not to forget to take the whole family history properly, like for example the breast cancer, ovarian cancer history, not only the female maternal side of history, bowel cancer in the paternal side, in the father or brother, can also be linked to sort of gynae cancers. So make sure we are taking proper history, personal history of breast cancer, BRCA mutation, we are all aware of these things leading to high risk of ovarian cancer. It's just we don't have to miss those histories in order to not to miss ovarian cancer. The third risk factor is endometriosis. So I just want to know, I mean, what is the practice for long-term endometriosis patients who are coming to our clinics? Are we doing regular scans or are we doing MRI scan? What are we doing here for long-term endometriosis patients?
Depends on the patient, mostly scans,
Ultrasounds?
ultrasound. Yeah.
Regular
Yeah,
scans, yeah.
ultrasound followed by MRI also at times.
At times, depending on the patient's present history.
MRI depending on the patient's condition and history.
Sure, sure. That is where I'm coming to. So, recently, I don't know why this happened, but I have operated like four clear cell cancers, all in less than 40-year age group, all developed into, long-term endometrioma and hematosalpinx. And they were only picked up because in West, there is a practice of doing MRI annually. I mean, we know that the endometriosis is never curable sort of thing. So any patient who's been on long term coming to you with repeat treatments, conservative treatment, or even a diagnostic laparoscopy, ablation, whatever, but if she has got a endometrioma or a hematosalpinx, there's always a high risk of a clear cell cancer developing in that hematosalpinx or endometrioma. The last patient I operated was a patient, 32 years old, hematosalpinx, 18 centimeter hematosalpinx. It grew in like a year time. She had MRI 2 years because of the COVID. Things were very, not regular. So she had a MRI done recently, and that was a clear cell cancer from hematosalpinx gone into the paraaortic nodes. So that is where it becomes a bit striking that endometriosis, we know it is a metaplasia, and from metaplasia converting to neoplasia, it will not take that long a time. So we have to be very sure that these patients are, I mean, even from today, any patient, if they walk into your clinic, hasn't got a MRI, please do an MRI. And if she's got a long-term history of endometriosis, then you have to do an MRI just to rule out. In an MRI, it's very easy. Even you can see if there are solid nodules in the blood-filled cyst or the tube, that is diagnostic of clear cell cancer actually. So MRI is a very classical picture with endometriosis. Next coming is the risk factor is the infertility. We know that infertility is a risk factor for ovarian cancer, and we have to be sure that whenever we are taking an infertility patient, we have to work up everything, and we are doing scans. I'm just sharing this because I have had a patient, again 36-year-old, came for IVF, had a scan done before planning for ovulation, stimulate ovarian induction, what they call that. So she had that scan done, and it was a 150 ml of ascites, no ovarian mass. So, but still, whoever was the doctor, it was suspicious of that. So they ordered a CT abdopelvis, and the CT picked up some peritoneal thickenings. There was no ovarian mass, but the CA-125 was 275, and 36-year-old can be, it's not very high. So the patient came to me, I did a diagnostic laparoscopy, I saw separate ovaries were normal, but there were separate peritoneal thickenings. I did a biopsy, it came back as ovarian mesothelioma, very poor prognosis. So this is something, it was very heartbreaking for me, for a patient who's planning to have a baby in a week time. Now her struggle will be to live for a year or 2 year. So it's a huge thing. So make sure the infertility workup includes these things, CA125 and scans, proper scans. The next risk factor is hormone replacement. I'm not sure how much we are giving it here. And obesity. Obesity is a risk factor for everything. So make sure that this is always in your mind. Now, when we say that this is so much, increasing, why don't we start screening the ovarian cancer? So the screening was actually planned. So in UK, one of our very prestigious Dr. Uma, she is a Indian origin gynae oncosurgeon based in London. She started this trial, UKCTOC, which actually took 2 lakh patients. Sorry, am I audible? There's some disturbance.
Yes, yes,
Very
audible.
much.
You're audible.
Yeah, yeah.
Very much.
So they took 2 lakh patients starting from 2001, and only 1 lakh were screened, and the rest 1 lakh women were not screened. And the end point of that trial was how many ovarian cancer death happened in those women by 2020. Now, they divided the 1 lakh screening group into 50,000. 50,000 were screened with multimodal screening, which is basically transvaginal scan and CA125, and the rest of the 50,000 were screened with only transvaginal scan. And there was a change. So 15% reduction of mortality in the multimodal screening and 11% reduced mortality, I mean death in transvaginal screening. Still, the answer of the trial was a big no to screening. And the reason for that is basically some more of UK based, I will tell. Because, I mean, all of the TVS and CA125 are, they are happening in NHS, which is a government sector. It's free of cost. So the cost burden in detecting these 15% and 11% ovarian cancer early was not actually, statistically significant. And that is the reason that ovarian cancer screening was declared as not to happen in future. So that is why the cancer nurses are doing the high risk analysis to find out which patients needs this screening. Now, when to refer? Usually this is something you already know. I'll just quickly go through. CA125 more than 200 in a patient who is premenopausal with a ovarian mass, and a CA125 of more than 35 in a postmenopausal women, again with the enlarged ovaries. So this is something. And then RMI, we are practicing RMI 1. If the RMI is more than 200, which is basically, as we all know, ultrasound score multiplied by the CA125 multiplied by the pre or postmenopausal status. If it is more than 200, then we have to refer to gynae-oncologist. And if you already have got a CT or a MRI, which is suggestive of ovarian cancer or primary peritoneal cancer, I'll just go through quickly with PPC. PPC is basically primary peritoneal cancer, which is 15% of the ovarian cancers, where I was actually highlighting that even if an ultrasound is showing normal ovaries, but a CA125 is raised, that means that she can have a PPC, which is again a cancer which is originating from fallopian tube fimria, but it is not enlarging the ovaries. So that is why the CA125 is raised because of the peritoneal reaction, but you will not see ultrasound picture of ovarian mass in these type of cancer. So that's it about that. So these are the points where, a referral to a gynae surgeon will help the patient. Now, yeah. So now the main question why we are discussing this, can you prevent ovarian cancer? So I want to ask again, how many of us are practicing doing salpingectomy in benign hysterectomies with conservation of ovaries? Are we
It's
already
yeah.
Now routine.
routine?
How
So
to
this
yeah.
is the first thing. Thank you so much if we are doing it in routine practice. The second prevention is tubal ligation. So I don't know how many of us are practicing, because I know in private tubal ligation is not that very common. But even if in patients you are doing tubal ligation, if a patient is coming to you with lots of abortion MTP abortion history, and she wants a tubal ligation, or but she's confused, this is something to tell her that apart from the advantage of contraception with tubal ligation, the ovarian cancer will also be, she will have free of what do you say, no
Reduced risk.
risk of
Reduced.
ovarian cancer if she's got
Reduced
this
risk.
ligation. So this is another advantage where you have to. The third point of prevention comes with endometriosis follow-up. As I was putting emphasis of MRI scans in endometriosis, one has to have that eye that this patient will need a MRI scan just to rule out a risk of clear cell cancer. So, and the last, I don't know how much our patients will be compliant. Like, for example, if you know there's a patient who's got a history of breast cancer, how much she'll come for follow-ups, I don't know how much it is possible here. Back in UK, we have got a register where we register these high-risk follow-ups, and the cancer nurses will routinely phone them up just to, know how they are doing and to ask them to come for the scans. But this is something.
Nothing over here.
Yes. But yeah, just wanted to highlight a study which was published in 2022, where in all 22,000 patients where the prophylactic salpingectomy was done, there was no cancer found, no cancer happened in 15 years follow-up versus the 15 cases of cancer were found in the control group where the prophylactic salpingectomy was not done. So just putting a second emphasis that we have to take the tubes out. So that is something needs to be done. Now, when a patient has already got a picture of cancer, when you know that she will be going to the gynae cancer surgeon, you already know that what we are doing. But just to give a idea of what she will be hearing from us, it will help patient a little bit. Like for example, if the cancer is localized in the ovary, we do not, if it is stage 1 or 2, we do not prefer biopsy. We will straight away go for debulking surgery. Even in nowadays, I mean, in Europe, there are so many trials which is happening and already proven the benefit of surgery even in up to stage 4. So what we are doing is up to stage 3, which is the cancer going till the omentum and lymph nodes, we are still doing primary surgery rather than chemotherapy. Even in stage 4, where there is a pleural effusion or a tiny lung lesion, which is the most common site. The pleural effusion and lung are the most common site of metastasis in ovarian cancer. Still, we are preferring for surgery. It depends on what type of tumor it is. So the patient has not have to, kill his or her hopes if it is a stage 3 or 4. Surgery is still amiable in stage 4. I have done it and I have seen good results with it. There are certain type of patients where surgery will not be feasible. There is already a criteria for that to differentiate, and on only those patients we advise chemotherapy. And for beginning the chemotherapy, we will need a biopsy diagnosis. That is when we do a biopsy and go for chemotherapy. Now, coming to just the end of the talk. So the take home message here is something: ovarian cancer is actually increasing in trends. What we need is to keep in mind the risk factors, which I discussed. There are a lot more. I just highlighted the little bit which are coming to clinics routinely. The signs and symptoms are very non-specific. So one has to have that low threshold of suspicion of ovarian cancer when it comes, on the symptoms and signs. The investigations we are already, I'm sure we are doing. Then the ideal, referral, the emphasis, we all know the importance of this, to go as early to the cancer surgeon as possible, but this emphasis needs to be, transferred to the patient, that yes, you need this as soon as possible. And then the prevention, which I discussed, and of course the counseling. So this is something, I mean, we are already doing, but yes, the patient needs repeat and repeat counseling, that for follow-ups. Like for example, an endometriosis patient will say, why are you doing an MRI? So they need proper counseling for these things in order for us to not to miss that cancer. So that's it for today. It's just a short presentation I made.
Thank
Whatever
you, Priya.
time.
Dr. Umar Rai has raised her hand.
Yeah.
Let's invite her first.
Yes, yes.
Ma'am.
Dr. Uma, ma'am. Ma'am, you want to ask something, ma'am? Dr. Uma, ma'am?
No.
No. Dr. Priya,
Let's
it
take
was really very nice presentation. Or I never expected it will be like so. You have made it very simple. The things, the way you
Yes,
have
I
explained.
honestly I
Yes.
wanted to put so many trials which are happening within. I thought maybe because when I was listening to such talks in my PG or whatever type, it was so boring. So I just wanted to be very specific. Just do this that thing about what I was discussing about pelvic mass clinic algorithm. I will. That was a very rough presentation. I will make a proper all four of them like ovarian, endometrial, cervix, and vulvovaginal. I know vulva is not that common here, but still, those four are something I think if are kept in all our clinics, it is not going to harm. I mean, it is something which is which sometimes can be skipped from our head, and then this will be.
Absolutely.
I request Dr. Sharda ma'am to say few words, ma'am. Dr. Sharda ma'am.
आप में तो अभी बहुत सारे experts हैं. Let them speak and then I will speak in the end.
Yeah. Okay.
But this is
Okay.
exactly
I'll ask
red
my
flag sign.
experts.
This is what the red flag signs are, that the general practitioners don't miss it out anything. And I think this is the difference between our teaching and their teaching. They are very specific. अगर इतना है प्रीमिनोपॉजल है तो 200 से ज्यादा CH 125 होना चाहिए, और अगर पोस्ट मिनोपॉजल है तो 35. I think all these things are they look very small, but they are not non-specific. They are very specific things which we call a red flag signs.
Yes. Our expert, Dr. Kiran ma'am, you want to say something? Dr. Kiran Chavda ma'am.
Hello, everyone. Good evening, everyone. Priya, your talk was very crisp and very clear. You have summarized everything very nicely. One thing I would like to know, if the patient's tumor markers are normal and there is a cyst we are operating upon, do we need a frozen section in that case also?
So, very nice question, ma'am. All the tumor markers are very unspecific. They are not very
Yes,
specific.
true,
Okay.
true.
So, that is when I'm telling you that the cyst will be found in an ultrasound scan, right? So, if the
Yes.
ultrasound scan is very sure and you trust the radiologist and they are saying that no, this is benign, go for it. No problem. Do a cystectomy. But
Okay.
even with the slightest issue, either with the scan, whether they are saying, oh, this looks a bit dodgy, or you don't trust the radiologist, either way around, just do go for an MRI, because MRI will be something where you will have an idea of either way. Frozen section is an option for fertility conservation surgery. So young patients having, of course, they don't go for directly salpingo-oophorectomy. They want a proper reason for going for that. So the frozen section is definitely an option. But MRI gives you a picture whether it is benign, cancer, or borderline. So that is something.
So take home message will be like, if you have any cyst in the ovary, you should definitely go for an MRI with all
As
the
I said,
patients.
if as I said, ultrasound, if it is clearly indicating no, it's a simple cyst, no need. But if it is inconclusive in ultrasound, go for an MRI, definitely.
Okay.
Yes. Dr.
Presentation
Vanna
was
Gupta
very
ma'am.
good. Really good.
Let's take comments from Dr. Archana. She's there. Dr. Archana, comments
Dr.
from
Archana Verma ma'am.
yeah.
Very good evening, and Dr. Priya. What I could listen only a very, I think 50% of your talk. I joined late somehow, but I could gather so much of good points from you. It was really very nice and crisp, as everybody is saying, definitely. And ovarian tumors is something, a name, even whenever we are listening. So this last year, at least 4 or 5, I don't know whether they were under your treatment in Delhi or not. They were two very high police officers' wife, and somehow giving me a frantic call, and that we have been diagnosed. We went just for the sake of ultrasound, and then ovarian malignancy was diagnosed. And then they were saying how common, and whether it is very, very dreadful something. And even we did PG in 85, and at that time ovarian cancer means already in fourth stage, and
Yes.
And then chances of survival very less. But still at that time we used to listen and remember that germ cell tumor and those other tumors were not so bad, and the staging is something very, very important, and not to fear from oncologist. And this epithelial tumors, of course, they were very deadly and very
Yes.
highly aggressive, and they were supposed to be. And ultrasound, somehow they say it misses. And there was one a doctor also, some medical legal happened to them. With when a patient was 45 years and she came with a ultrasound report of this ovarian cyst, why you did not advise CA-125. So
No, this is something
Nowadays,
I wanted to.
nowadays more and more patients are coming to us with ovarian cysts. So they come early also. If we try and go for further tests, maybe we can pick them up faster.
Yes, that's
Yeah,
that's
yeah.
very
So the
important.
moment the cyst is diagnosed on
Moment
ultrasound,
the cyst is,
they,
yes,
they
yes.
come for a second opinion. They
They
definitely
land
go
up
in
to the
for a second.
gynecologist clinic for opinion. So we should
Yeah,
always go for a CA-125 with every
yeah,
patient, so that
Yeah.
we have
Doctor,
some
That is right.
idea of where we are.
yeah. I'm just
Yeah, yeah,
telling
yeah,
you
yeah, Priya.
again one
Yes,
thing.
Priya.
Not even ultrasound saying a ovarian cyst with the set of symptoms I was telling you, a CA-125 is must. That's when
Yes,
the flow chart is different from UK to us. We only do I mean, maybe the thing is changed here, but when I was practicing, we do CA-125 when we see a ultrasound showing a cyst. That
yes.
is not the right way what we are doing.
Approach.
We do a
Okay.
CA-125 first as well as ultrasound. The reason is because of the PPC, the primary peritoneal cancers, or even the reaction happening. The CA-125 is a first marker to raise if it is a epithelial origin cancer, even before becoming the ovarian mass. So the set of symptoms I was telling, if that type of
Yes.
patient is coming, no harm in doing a CA-125. I mean,
yes.
we know, we can tell
Most
the
of
patient.
the patients come these days with bloating, feeling of bloating and bladder and these habits. So we should get it done in those cases
IBS,
also,
yeah,
according to you.
IBS.
Yeah.
Ma'am, आप muted है. Ma'am, आप muted
let,
है.
let all consultants who are experts, let them make a comment, and then the discussion will
Yes.
follow. Please.
Our two experts are there, Dr. Leena ma'am and Dr. Divya ma'am. I request Dr. Leena ma'am first and then Dr. Divya ma'am, please. Dr.
Okay,
Leena ma'am.
okay. So I'll be very quick. And well, thanks to Dr. Sharda ma'am for discovering you, Dr. Priya. I mean, I'm so happy that I'm heard your talk. It really, it was in a such a like you say, covering everything in a nutshell. And so, all of us, I mean, we have really gained a lot by hearing and listening to you. My quick thing is one. CA-125 is nowadays being routinely done, when people are going for their health checkups. But just one thing, and what I'm seeing is one of my patients, she was extremely worried because, her CA-125 came 25, and so she was referred by the health check people who go to the gynecologist. And, I mean, she was just about 35 or 37, something like that. And I had to do a lot of tests and convince her that everything is fine. So, it can work the other way around also, but
Yes.
yes, yes. So that is there. And I really love that particular slide that you put about, perimenopausal and postmenopausal cutoffs of CA-125. Please share that again so that, we all also can put it up, including the, examination of the pelvic mass. We like to put it up in our OPDs. The other point which you mentioned is about tubal ligation giving you a, some decreasing your risk of
Ovarian cancer.
ovarian cancer. I think a person like me in a corporate hospital, that's something that I'm going to capitalize upon when I next counsel my patients, because we have a lot of less people, opting for tubal
Yeah.
ligation in the private
Yes.
sector.
Yes.
So that will be something I think very. It was a nice point that you highlighted.
Yes.
And of course, endometriosis. I find so many of our endometriosis patients are very happy with medical management and are carrying on endlessly. So it is wise that we mention this particular point to them and ask for an MRI so that we can pick up any changes if at all they happen
Yeah.
in the earlier stage.
Actually,
That is about all. I think it was a great learning experience in this very first webinar in the midlife, and I'm so glad you started with ovarian because like you just mentioned, there's such vague symptoms. So
Yes.
they can easily pass off in a in a busy OPD, um, and we should be even if we
Low
do.
threshold, yeah.
Yes.
You should know the cancer in head when to catch it. That's,
To catch it. Yeah,
yes.
yeah. So there was one thing that you mentioned. I just want you to reiterate that, and that is that you mentioned about a higher CA 125 and not seeing anything. You mentioned that that should be the time when we go in for a MRI, because ultrasound is very operator dependent, and it also depends on the kind of ultrasounds the patient has gone to and what center they've gone to. So can you just highlight
Yes.
that point again so that it's a little bit more clear to me?
So this is something when I come to you, thank you, you asked that. Actually, this is a very, gray area, I would say. So CA125, as I said, non-specific marker. I have seen CA125 2800 in just a endometriosis. It was not cancer. So, and I have seen CA125 up until 28,000. The zero was not mistaken. I cross-checked that in endometriosis, not cancer. So CA125 can be raised, in anything. So that is when it comes. So what I was explaining is because of the crossover of UTIs or chest infection or things like that, or even menstruation, giving a CA125 or say 80 or 84. So the patient will be in a postmenopause, not in postmenopause, premenopausal, but the patient will come
Premenopausal.
to you because वो जो lab वाले लिखते हैं वो more than
35.
35 abnormal लिखते हैं, but we know more than 200 is the concerning. So in that patient, rather than hassling the patient for MRI, if clinically we examine the patient, we do a CBC is normal, not everything, then go for just ask the patient to come back in 4 weeks, repeat a CA125, and then you will get an answer. If it is going up, definitely something is wrong. If it is going down, then there was something inflammatory going on that was raising the CA125. So this conservative approach is only for gray area CA125. I will not send home a patient who's got a 500 of CA125. No, that patient is not going home. That needs something. So that gray area I was talking about. Thank you. You asked that.
So Pratibha is also
Dr.
here.
Divya ma'am?
Pratibha.
Dr. Pratibha. Dr. Pratibha, unmute yourself.
Dr. Pratibha single.
Is Pratibha Garg out here?
No, Pratibha single. We have invited her from Noida. Dr.
Divya is
Divya
here.
ma'am,
So
Divya
Priya,
single
a
ma'am.
few
So,
things.
so good evening, madam, and good evening, everyone. Fantastic talk by you, Dr. Priya Bansal. You've made everything so crystal clear. I really want to thank you for it. And the very fact that we must do a CA125 and an ultrasound every year is one take-home message I am going to take back. And I request all of us to get it done for ourselves as well. And the beat it. Can you beat का जो आपने acronym बताया है, that was fantastic.
Yes.
It'll stay and it's going to beat ovarian cancer to quite an extent. I hope so. And this was absolutely new for me when you talked about prevention of ovarian cancer with bitubal ligation, and salpingectomy also helps in that. All those 4 points that you mentioned, and of course about the primary peritoneal cancer that you mentioned. This was also new to me, so that's why the importance of doing the CA125 before we think of just the ultrasound. And just one question, that if you could elaborate whenever there is time after the discussions on IOTA score, and if it's of any significance
IOTA score,
any
ma'am,
longer.
is not. We are not practicing in UK, so we are just doing the the ultrasound scoring for the RMI, which is basically either the bilateral lesion, ascites, solid areas, irregular papillary, those things. IOTA is practiced. I think in Africa it is a lot practiced because of the MRI is not that readily available. In here, I think the MRI is available, so the credibility of ultrasound with stamping something as malignant and benign is not that very important. I mean, even if you ask a low socioeconomic patient, if you tell them to this is suspicious of cancer, they will come back with the MRI themselves. So this is something. So IOTA is good. It is really good, and so I think it is. I have got a colleague from Egypt. So she told me that they are not doing MRI before doing cytoreduction. They depend on their ultrasonologist and they are doing iOS coding. I said, I don't think that's going to happen in India. But these are some things, we have to, with our region, with our population, with the medical legal things on the top of head. So we have to. So IOTA is good, no doubt about it. I've seen people doing things and without any troubles. So,
Thank you.
Thank you,
I
Priya.
will say,
Dr.
Dr.
Sharda
Priya,
ma'am, please sum up the
yes.
things.
I think Dr. Priya, everything made by presented by you was new to everybody. Let me be very frank with you, whether they admit or they do not admit. Secondly, is I am a wife of a pathologist, so I know it. CA125 has become one of the screening methods, especially past 50 years. People should definitely do it, because this could be one of the sign of epithelial malignancy coming up, whether directly from the peritoneum and this thing. And as far as for the self-injectomy part was there, now it has been almost a decade. The question is not there that in case if you're doing a hysterectomy for benign lesions, you definitely subject for self-injectomy. But this is a news to me that even doing a tubal ligation can help her. It means the tubal ligation means not tubal ligation. It is the self-injectomy which is going to help the patient of a future no malignancy as far as the ovarian pathology is concerned. And let me be frank with you, in the last 3 years, very close friend of ours, they said, I'm having a little pain in my abdomen. I want to come down for an ultrasound from Dr. Jyoti. I think, each one of you must have remembered it, that, in COVID times, we started that, around 8th of March, we will get an MRI done. And we suggested that all gynecologists should get an MRI done. And we found that in spite of publicity, only 10 got it done, because एक बात मान के चलिए, MRI is MRI in comparison to early detection. And all these 3 people who are very close to me, and they are struggling with the stage 3 cancer, they did not have any symptoms at all. MRI it was picked up as a stage 3 disease. Pain of only 1 week. 1 week, 10 days, 15 days. So this is what I think, we are not talking about the public, we are talking for our own selves. हमें अपनी स्क्रीनिंग कराओ, जिंदा रहेंगे तो ट्रीट करेंगे दूसरों को.
बिल्कुल.
So I think we must get obsessed about it. We must respect our age, and as far as beyond 50 years, even if you do not have any disease, twice a year checkup is required, and all this entails. I think I'm absolutely delighted, Priya, with your presentation, and I think this trick worked. It is excellent.
Yes.
It is absolutely wonderful. Wonderful.
Thank you so
Really,
much.
she has put our thoughts on streamline. We did have vague ideas.
No, Vandana, let me be. The teaching in UK is this kind.
Yes, wonderful. It streamlines everything for you.
Teaching in UK is this kind. जो उनको लगता है बेकार है, वो पैसा नहीं खर्च करते उसमें.
नहीं, really.
They are very clear कि किस पे पैसा खर्च करना है.
Right.
So that's why they hammer it out as for the general practitioners are concerned. And this is what I told her. I said, Doctor साहब, अगर आपने popular होना है, तो पहले आप दो, और आप वो सारी चीजें सिखाओ जो वहाँ general practitioner को सिखाते हो.
Right.
And I think that is going to work. Each one of us who was present here go rich after her presentation.
Absolutely.
Thank you so much,
Right.
everyone. I'm
And
just
Dr. Chaturvedi ma'am wants to say something. You want to ask something?
Yeah.
Right.
Yeah.
Dr.
Priya,
Chaturvedi,
I just want, hold on. I just want to
wanting,
ask Priya,
like he's talking
just
very.
a minute, Dr. Chaturvedi, just a minute. I just wanted to ask that a scan be an ultrasound scan, a plain PS, or would you be seeing the PS with close MRI?
sorry, ma'am. Is it my
Vanna
internet
ma'am,
that I
आपका ना net, there is a net problem. Dr. Vanna Gupta ma'am.
Network, is it audible now?
Voice is breaking.
Okay.
Somebody is asking, tubectomy is normal tubectomy or a self-injectomy type?
salpingectomy will definitely reduce it, but tubectomy has also been proven in 3 types of ovarian cancer, which are high-grade serous, clear cell, and endometrioid, reducing the incidence. So it is not effective in low-grade serous, but otherwise only tubal ligation, the original way of doing it, is also helpful. So this is something to counsel about. Sorry,
Right.
Vanda ma'am, I couldn't hear you.
Yeah. I'm audible now.
Yes, yes.
Yeah,
Am I
now
audible?
you're clear.
I was asking, they are doing a TVS scan, a plain scan, or a color flows versus an MRI.
Yeah, I'll tell
Color
you.
flow.
So, plain scan in the beginning. If you see a mass, then of course use the color flow.
Color
Color
flows.
flow you must
So,
do.
so color flows would add on to the information to the MRI, or MRI would
Yes.
suffice.
Yes. No, no, no. If you
It-
are going
because
for
it's far
MRI,
sensitive.
if you're going for an MRI, then color
Then
flow.
we
No
don't
color
require.
is required. It
No
makes
color
it
flow. No
extra.
color
There's
flow.
no additional things.
Okay. Okay.
Only if you
MRI
do
with contrast.
ultrasound
With
and you want
contrast.
to be doubly sure, you can do color flow.
Right.
Otherwise, if you have thought for MRI, so you don't
Then
need.
yeah, like
Right.
if you are
You
just
don't.
declaring the cyst for benign and you are not
Yeah.
going for MRI, then
When it is very thin capsule and clear, no echoes, then it's okay. Don't go for a simple cyst.
not needed.
Right.
One thing that I wanted to ask you, we had a young patient. She had a cyst which was growing also slowly and which had various things inside the cyst. And the radiologist had diagnosed dermoid 2 or 3 times.
Hmm.
And then we had also done a CA 125, and it was around 87, 90,
Yeah,
something like that. So confusing and dilemma stage because the patient was young.
True.
So we watched her for 2, 3 months.
Yeah.
Then we took another opinion to the other person also. They were also confused. MRI also was done, but nothing came out to be very substantial. And then others said better you get a oophorectomy done. So one side was that right or no?
So I will tell you what was the final diagnosis finally actually.
Same thing came in
Dermoid.
HPV. Same.
Yeah. So I would say, I mean, like, this is something you did the right thing to, watch the cyst for 2, 3 months, which is the right thing because C125 was something around 80. So it's not, and the trend, I'm sure you
Yeah.
may have seen the
Yeah.
trend as well of CA125. If it is not rising, so then that CA125 is just inflammatory. Coming to the MRI picture of dermoid, usually dermoid are very easily diagnosticable. Like in MRI, if you see fat, that means, I mean, it's a dermoid. However, I have seen one patient, I mean, again, because, sometimes if you see with the cancer surgeon eye, you see cancer everywhere. So I have seen one patient, dermoid only, but she wanted it out. So I took it out, and there was a focus of mucinous cancer coming from bowel. She had a CT scan, nothing in bowel, but that dermoid was having a mucinous focus coming. So abnormal things can happen. I would suggest, if I would have been in that place, the young girl, go for a surgery, have a frozen section done. But frozen section also can be, it's just a piece of tissue. You cannot see the whole tissue. So if you are even left with one ovary, it's hardly going to affect the fertility. It's still okay, but at least you will be ruling out that small risk of leaving the cancer there. Because I mean, there was one patient I had to take transfer her care before coming to India. She was 22-year-old, diabetic, young, unmarried, of course. She had this ovarian cyst which was query borderline tumor on MRI scan. I advised her to have salpingo-oophorectomy. With my eyes, it's always like that. So I said that let's do a USO because it is already by my radiologist who's trained in gynae cancer only. They said borderline at best. So that is something stamped.
Again.
I said go for salpingo-oophorectomy, but she was insisting on cystectomy. I want to preserve my ovary. I'm just 22. Well enough. So we took a opinion of IVF consultant. We have to take second opinions within the hospital, and he also said that losing one ovary will not affect your fertility that much. We can do a lot of other things. One ovary and one tube is still intact, but this borderline tumor can affect a lot. So that is something from my eyes. If there is a suspicion, don't go for cystectomy, go for oophorectomy because one ovary is still okay. So that is, I mean, maybe more radical approach, but I think
No, it's
having
not radical. It's very rational, I would say,
yeah.
because if it increases, it jeopardizes her whole life.
Definitely.
Right,
Yes,
right.
Dr. Sharda Jan, ma'am, you want to say something?
And I don't want to say anything, but I think the people after asking question must mute themselves and do not fiddle with the key which is there, because
Because we were
somebody
not able to hear in between.
it becomes very difficult.
Yeah. It was very nice topic today. We have learned so much, Dr. Priya and
Thank
Dr.
you.
Sharda Jan, ma'am. Your vision is very good. That will help us in future. And next, again, every 5th of the month, we are going to have one topic regarding cancer. And in between, we'll keep on having your suggestions, views. You keep on posting in the group, then it will be helpful to us. And
Sure.
any cases that you come across, then you please let us know. Thanks a lot, Dr. Priya.
So my
And
request to Dr. Mabatra is that that you are a chairman of the midlife club. Consistency is very much required. When we have said that we have started it, we said it is going to be on the 5th of the month. It should not be that एक महीना हो, 2 महीना हो, तीसरे महीने गायब. It is a consistency which is required.
yes, it will be for 365 days, ma'am. Thank you, ma'am. That will be there.
I think I'm glad that 55 to 60 people joined this particular thing, and we definitely go wiser. And I again thank Dr. Priya. It was wonderful. It was simply wonderful.
Excellent.
You definitely
I
alerted
want to
all
thank
of
all
us.
my experts
Signs, red
and
flag
all
signs.
those who have joined.
Yes.
And those who have joined, thanks a lot.
Promised her that we will give you the audience of 30 people, and we made it to 60 people. Thank you very much.
Thank you so much. I mean,
Thanks a lot, ma'am.
Next time with word of mouth, we will get 120. Hope so. We cross 100.
Which
We will not
answer
have
you
100
want
because
next
this
is
platform
something
is
I
only
need
for
to
100
prepare.
people. This platform is
Yeah,
only
100.
for
At
100
least
people.
we'll reach the max. We will definitely reach the max.
Yes.
So, which cancer would all of you like? Cervical or endometrial? Which?
Next cervical. Go for cervical.
Cervical.
Okay, fine.
Right.
All right.
Because that's the mission also, no? Cervical cancer Mukt Bharat.
Yes. Yes.
So that'll be great.
How those people have screened in the last 65 years so diligently, वो वाला भी part highlight करिएगा.
Definitely,
Right.
ma'am.
And she mentioned time and again that they have cancer sisters. They are
Nurses.
specifically
Yes,
trained. They interact in the OPD. They go about talking to them, asking, getting the symptoms. These are the asymptomatic patients where they force them to get the examination done.
Madam, there
I
they
mean,
send
UK,
the, there they send the notification for pap smear that when it is due.
It is a
It
letter.
comes from the
Everywhere.
NHS only.
It's not only
in
in
UK
UK, even
directly,
India.
you won't be
In UK they do it.
indirectly, you won't be able to get
यहाँ पर
doctors.
वहाँ पर
Only
ये होता है,
sisters are
system ये
working more.
बताएगी. System in UK is like this, that all of us 50 people are given time that they have to come for a pap smear. So in the morning they screen कौन लोग नहीं आए, माने 7-8 लोग नहीं आए तो उनको उसी टाइम अपॉइंटमेंट देंगे. और नेक्स्ट टाइम अगर आपने अपॉइंटमेंट के टाइम पे आप नहीं होंगे तो वहां पर वैन दौड़ के चली जाएगी उनके घर. So they are that kind of
Healthcare
seriousness is
facilities
there,
बहुत है ना.
because अंग्रेजों से कुछ तो सीखना ही पड़ेगा यार.
In UK, all the
Ma'am,
sisters
हमें
are
मोदी
more,
जी
they
से
are doing
कहना
their work.
चाहिए,
Ma'am,
मोदी जी से
ma'am.
कहना चाहिए हेल्थ केयर फैसिलिटीज का बजट बढ़ाएं.
Actually.
The thing is,
But ma'am,
that
you're
is
absolutely
something
right.
required.
हमने मैम फ्री
That is
करवाया था
required, ma'am.
for our own employees, through the HR we had got like all these kits and for doing a liquid based cytology, and manpower is going to be free. Like I would do it, the pathologist would see it. Still, what we thought, they calculated 256 female. We found not even 50% turned up. The people are scared. I don't know. They just don't want to get screened. I keep telling them, look, I'm going to be very gentle, but come, you're getting an opportunity to get it done free. But still, the thing is that कुछ निकल आएगा. I said, कुछ कैसे निकल आएगा? जब कुछ होगा तभी तो निकलेगा.
प्रिया, एक काम हम कर
lots
सकते हैं,
of,
पब्लिक
counseling.
अवेयरनेस के लिए भी we can prepare a lecture so
But
that
that is
people
true,
are
yeah.
aware of what are the symptoms basically.
Dr. Priya, I wanted to ask one question.
Yes.
Yeah.
जी, Dr. Meena.
Yeah, Dr. Meena, carry on.
I was asking, initially we used to do tumor ligation, keeping in mind that recanalization can also be done. But now what you suggest, that it should be salpingectomy?
No.
You can
So
you can
she
do
has she's opened her mind to you. This is exactly what she has said. It is patient को self injectomy कराने में बड़ी परेशानी होती है. बहुत कम लोग तैयार होते हैं डॉक्टर साहब.
and that is why even that only the normal tubal ligation which we are doing is also preventing us from ovarian cancer. It's not only salpingectomy, the tubal ligation. If you go and Google and search, I will present that trial, or I will put that trial link in our group, in midlife group, for all of
Sure.
you to read. Okay, so I
Sure,
can
sure.
do that.
Okay.
Do
So
that.
that will clear the confusion of, yeah.
Sure.
So
Thank you. Thanks a lot, Dr. Priya.
thank you, ma'am.
Thank you, ma'am.
Thank you, Dr. Priya.
Thank you,
Thanks all
Priya.
It was
experts and
really
those who
very
have
nice
joined.
presentation.
I must tell you where Dr. Priya is located. Dr. Priya is located in Fortis Hospital, Noida, in Greater Noida, and she's also present in Greater Kailash. So this is for all of you to know, and we will definitely put her number in the group.
Sure,
So
ma'am.
nice of you, ma'am. Thank you so much.
So nice.
The great initiative.
Thank you.
Okay,
Thank
Priya.
you, ma'am.
For
Okay.
Thank you
listening,
See you
and
so
thank
next.
you.
See you
Thank
next.